Hello, ready to master pharmacology? Let's dive into the video.
Today we are going to see about the one of the most important topic in pharmacology, which is the cardiac glycoside. So it is a drug which is used in heart failure. So there is a right heart failure and left heart failure. So in left heart failure, what happens is that the ventricles does not pump. Okay, when the ventricles does not pump, there's decreased blood supply to the organs, and it causes ischemia and hypoxia. So what happens when the ventricle does not pump is that there is regurgitation of blood which is accumulated in the ventricles into the left atrium. So then it travels to the pulmonary vein and then to the lungs. So when there is accumulation of the blood in the lungs, it causes pulmonary edema that causes dyspnea and fatigue, lethargy, etc. So in that cases, we can give a drug with positive inotropic effect, which increases the force of contraction. So in that cases, we can treat the patient by giving positive inotropic drugs like cardiac glycoside, sympathomimetics, and phosphodiesterase 3 inhibitors. So today we are going to see about the cardiac glycoside. So cardiac glycoside are the drugs which have the positive inotropic effect, which means it increases the contraction of the heart. It increases the cardiac output in a failing heart without increase in consumption of oxygen. It differs from the other cardiac stimulants like adrenaline and theophylline because these drug causes increase in oxygen consumption and decreases its efficacy. Okay. So in cardiac glycoside, we have digoxin, digitoxin, obain, bufotoxin, etc. So what are the sources these drugs are obtained from? Okay, we have the plant source and animal source. Digoxin is obtained from a plant source called as the Digitalis lanata, and digitoxin is obtained from Digitalis purpura, and obain is obtained from Strophanthus gratus, and bufotoxin is obtained from torch skin of animal. So currently only digoxin is used widely, which is obtained from Digitalis lanata. Now let's see the pharmacological action of digoxin. Okay, so on heart, it has three actions. Okay, first is contractility. So when it comes to contraction, we already saw it increases the force of contraction. Okay, so in failing heart, it increases the stroke volume and decreases the diastolic volume. Next is heart rate. So digoxin causes increase in heart rate. If you ask why, it is due to increase in vagal tone. Okay, so when there is increase in vagal tone, there is depression action on the SA node and the AV node. Okay, so there is bradycardia. Next is electrophysiology. It causes a decrease in RMP, it as well as decrease in phase 4 depolarization. So it causes slower conduction, and it increases the phase 4 slope in the Purkinje fibers, which causes ectopic beats, which means that rhythms are not only from the SA node, it also has the rhythms from the other parts of the heart. So that is the ectopic beats, which may lead to arrhythmia. Okay, so on the whole, it decreases the action potential. Next is the ECG change. In ECG change, it causes inversion of T wave, increased PR interval, and QT interval. So why this increased PR interval occurs? So this is a heart. So what is PR interval is that time interval between the signal from the atrium to travel into the ventricle. Okay, so for the signal to pass from atrium to ventricle, it has to pass something called as the AV node. So this digoxin causes slow conduction of AV node. When there is slow conduction of AV node, there is prolonged PR interval. Okay. Then if you ask me why there is a decreased QT interval, it is because of the accumulation of extra calcium. Okay, when there is accumulation of calcium, this causes a shortening of the ventricular action. Okay, so when the ventricular action potential is shortened, it leads to the decreased QT interval. Okay, and then there is ST depression. Moving on to next action on blood vessel, it is not that much important. In normal individual, it causes an increase in peripheral resistance, and in chronic heart failure patient, it causes a decrease in peripheral resistance. So the net effect is that it has no major effect. Okay, moving on to the next. The next action is on kidney. It causes diuresis in patients with chronic heart failure. So due to diuresis, there is increased renal perfusion and there is increased circulation. and on CNS it causes CTZ stimulation, and that leads to nausea and vomiting. It also causes hyperapnea, and it causes CNS stimulation, which leads to confusion, delirium, and visual disturbance. Okay, coming to the mechanism of action of digoxin, it inhibits the sodium potassium ATPase. Okay, first I'll tell you the normal physiology which happens in a myocardial cell. So this is a normal myocardial cell. Okay, so we have the sarcoplasmic reticulum, this is the cytoplasm, and these are the receptors present on the myocardial cells. First we'll see about these L-type calcium channels. So this L-type calcium channels lets in 1% of the calcium into the cytoplasm. This calcium now binds to the RYR2 receptors present on the sarcoplasmic reticulum. Now this binding causes the abundant release of calcium into the cytoplasm. Okay, so when there is abundant release of calcium in the cytoplasm, it binds to the troponin C and it causes contraction of the myocardial cell. Okay. What happens after the contraction is that the abundant calcium which was released by the sarcoplasmic reticulum is taken up back by the SERCA receptors. Okay, this SERCA receptors takes back the abundant calcium which was released by the RYR2 receptors. Okay, now what happens is that the calcium released by the L-type calcium channel must be taken back, right? It is done by the sodium calcium exchanger. So this sodium calcium exchanger takes back the calcium outside and lets in the sodium inside. Okay, now this sodium has no role, so it has to be let out. So this is done by the sodium potassium ATPase, which is present on the myocardial cells. Okay, so this takes back the sodium which came in and it lets in the potassium. So once again, I'll repeat the normal physiology. The L-type calcium channels lets 1% calcium inside, which binds to the RYR2 receptors and present on the sarcoplasmic reticulum, and that causes abundant release of calcium, and that binds to the troponin C and causes contraction of the myocardial cell. So after that contraction, the abundant calcium which was released by the RYR2 receptors is taken back by the SERCA receptors. After that, the 1% calcium which was released by the L-type calcium channel is let out by the sodium calcium exchanger. This sodium calcium exchanger lets in 3 sodium inside and takes back the calcium. This sodium has no role, and it is exchanged by the sodium potassium ATPase. This sodium potassium ATPase takes in the sodium and lets out the potassium in. Okay. So what is the role of digoxin here? So it inhibits the sodium potassium ATPase. So when it is inhibited, there is intracellular accumulation of sodium. Now this receptor, sodium calcium exchanger, does not work. So there is accumulation of calcium which is released by this L-type calcium channels. What is the mechanism of action of digoxin? It inhibits the sodium potassium ATPase. So there is increased accumulation of the intracellular sodium. So the sodium calcium exchanger does not work anymore. Okay, so the less calcium is pumped out, and so there is more accumulation of calcium inside the cytoplasm. So when there is increased calcium accumulation inside the cytoplasm, again it stimulates that RYR2 receptor which was present in the sarcoplasmic reticulum, and it further promotes the contraction. There is stronger contraction of the myocardial cells. Okay, let's revise this one more time. So digoxin inhibits the sodium potassium ATPase. So when the sodium potassium ATPase is inhibited, the sodium cannot go outside, and there is intracellular accumulation of the sodium. Now the sodium calcium exchanger does not work because the sodium cannot go out of the cell since this receptor is inhibited. So the sodium calcium exchanger does not work anymore. Okay, so less calcium is pumped out, so there is intracellular accumulation of calcium, and that calcium again binds to the RYR2 receptors present on the sarcoplasmic reticulum. So that causes more release of abundant calcium again, which causes binding to the troponin C, and that leads to the contraction of the myocardial cells. Okay, next is the adverse effect. So if you see the therapeutic index of the digoxin, it is very low. It has a very narrow safety margin. Okay, so even plasma level of more than 1.1 nanogram causes high mortality rate. Okay, it has two manifestations, which is the extracardiac manifestation and the cardiac manifestation. So in this we have the GI causes, which is the anorexia, nausea, vomiting, which we saw it is because of the CT is at stimulation. Next is the abdominal pain. In CNS stimulation, we already saw it causes fatigue, headache, confusion, disorientation, restlessness, psychosis, and hyperapnea. It also causes visual disturbance, which is a green yellow vision. Other adverse effect is skin rashes and gynecomastia, which is rare. Next is the cardiac manifestation. It causes all types of arrhythmia because there is accumulation of calcium. So extrasystoles, tachyarrhythmias, and it also causes the conduction blocks, bradycardia, etc. Okay. And how to manage the digoxin toxicity? First, you withdraw the drug. In mild cases, it resolves after the withdrawal. Further, we have to proceed for specific treatment. For tachyarrhythmia, it occurs due to chronic use with diuretics. So that leads to hypokalemia and that causes digoxin toxicity. So in that cases, we can give potassium chloride IV. In ventricular arrhythmias, we can give lidocaine, and supraventricular arrhythmias, we can give propranolol. In AV block, we can cause atropine. Okay. So next is the antidote. So digoxin toxicity, we have an antidote called as the specific Fab fragments. So this Fab fragments binds to the digoxin and it forms a digoxin Fab complex, and that leads to the excretion of digoxin rapidly in the urine. So this can be used in the digoxin toxicity. Next is the contraindications. So we'll see the patients with high risk of toxicity. First is the hypokalemia patient. We already saw when there is decreased potassium, the ability of the digoxin binding is more. And in elderly patients and the patients with renal hepatic disease, because it causes poor clearance. Next is the myocardial ischemia and thyrotoxicosis, which have the risk of arrhythmias. And in mixed edema, there is slow elimination of the digoxin, so that causes accumulation of digoxin, which leads to the toxicity. What are the absolute contraindications? So absolute contraindications are ventricular tachycardia, which may precipitate the ventricular flutter, and in partial AV block, because already digoxin causes AV block. So partial, when the patient is already with partial AV block, it may progress to the complete AV block. Okay, which is very dangerous. Next is acute myocarditis because of its poor inotropic response, and in Wolff-Parkinson-White syndrome, in which the abnormal atrial impulses reach the ventricles and it causes ventricular flutter. So coming to the drug interaction of digoxin, so we should not combine digoxin with diuretics, because all the diuretics except the potassium sparing diuretics have the ability to cause hypokalemia. So digoxin and diuretics should not be used together because it may lead to toxicity. Next, calcium. So already digoxin causes calcium accumulation. So when there is more calcium, it may lead to arrhythmia and toxicity. Okay. Next is with the quinidines. So the quinidines decrease the binding of digoxin to the tissue proteins, and it decreases the renal and biliary clearance by inhibiting the P-glycoprotein efflux pump. So it causes toxicity. Next is with the adrenergic drugs, because it increases the ectopic automaticity, which is the abnormal signals from the other parts of the myocardial cells other than the sinus node. It can trigger the arrhythmias. Next is the drug affecting the digoxin absorption. The drug which decreases the absorption are metclopramide, sucralfate, antacids, neomycin, sulfasalazine, and the drugs which decreases the absorption are atrophic drugs like antimuscarinic and tricyclic antidepressants. Next, it should not be combined with the depressing AV conduction because it leads to the complete heart blocks. So such drugs are propranolol, verapamil, diltiazem, and diisopyramide, which is all of these are the calcium channel inhibitors. Next is with the succinylcholine that can trigger the arrhythmias. Okay. Next we'll see the uses of digoxin. So the main indication of digoxin is only two. It is used for the congestive heart failure and other for the control of ventricular rate in the atrial fibrillation and flutter. So what is meant by control of ventricular rate in atrial flutter and fibrillation? So atrial flutter and fibrillation both have abnormal atrial rhythm, right? So that signals should not be passed on to the ventricle. So when it is only confined to the atrium, disease progression is not too bad, right? So controlling of the ventricular rate in the atrial fibrillation is the other use of the digoxin. So we'll see the uses in detail. So congestive heart failure, The pathophysiology is that either it has the systolic dysfunction or diastolic dysfunction. In systolic dysfunction, there is dilated ventricle, so there is poor contraction of the ventricle that leads to the decreased cardiac output. In diastolic dysfunction, there is stiff ventricles, so there is impaired filling of the ventricles. Okay, so that also leads to the decreased cardiac output. So in long standing cases, the patient have both. So what is the effect of digoxin in heart failure? It increases the contractility, so that leads to the increased stroke volume, that and it causes a decrease in end diastolic volume and filling pressure, that causes less venous congestion or pooling of blood in the legs. Next, it decreases the heart rate by increasing the vagal stimulation, so that causes more efficient filling. Okay, then it causes improved renal perfusion, that causes increased urine output, and so there is decreased edema and pulmonary congestion. So one thing you must know is that digoxin improves the symptoms, but it does not reverses the cardiac remodeling. Okay, it only gives the symptomatic treatment. Next is cardiac arrhythmias. First we have the when atrial fibrillation, next we have atrial flutter, and at last we have the supraventricular tachycardia. In all these cases we have the same mechanism, which is nothing but there is increased effective refractory period of the AV node, so that causes decreased number of impulses conducted from atria to the ventricles. So in atrium we have the abnormal rhythm. This abnormal rhythm must not pass to the ventricles, because if it passes to the ventricles, it is very difficult to treat. Okay, so we can keep it confined to the atrium, but how it can be done is by increasing the effective refractory period. When the effective refractory period is increased, there is decreased number of impulses passing from the atrium to the ventricle. Okay, so the abnormal rhythm does not pass to the ventricles, so the ventricular rate is unaffected. So the same mechanism is for the atrial flutter as well as the paroxysmal supraventricular tachycardia. Okay, so that's it for the video. Thank you so much for watching. If you really found it useful, please do like, share and subscribe.